My whole dream of this podcast series and sort of the whole Behind the Drapes network of podcasts that I've created is to create content with my friends. I've been fortunate enough to make friends who are becoming excellent physicians, and this episode is an example of that. Jeremy was one of my best friends in medical school and part of our tight knit group of friends who really made medical school one of the best phases of my life. In this conversation, we talk about what his life is like being an orthopedic resident, mostly about what his trauma experience has been like. He takes us inside of a trauma bay, what the primary and secondary surveys look like, and what constitutes as orthopedic emergencies, how he handles them in the trauma bay, and what he needs to take to the operating room right away, as well as what types of things can wait in the ICU and come back at a later time. These are some of the most fun conversations I think I have on these podcasts when I'm just talking to my friends about medicine. And it's so cool to see the progression we've made from playing 2K and eating frozen pizzas on our couch that's been broken for 6 months and it's like 11 p.m. at nighttime and we don't have a care in the world to now realizing that we both need to go to sleep before 10 o'clock so that we feel somewhat rested for our next day that starts around 4 a.m. in the morning. So stay tuned to listen to this fun conversation with my buddy Jeremy, and welcome to Collecting My Observations.
Welcome to Collecting My Observations. Enter into the stream of thoughts that flow through the mind of an ICU fellow who is on his way to becoming an anesthesiologist and intensivist. This is where patients live on the verge of life and death.
Welcome back to Collecting My Observation. This is episode 5, and we have a very exciting episode ahead of us today. When I started this whole podcast series under the umbrella of Behind the Drapes, I kind of started doing it as something where I interviewed others. And this recent series has really forced me to develop my own voice and kind of find my own podcast character. And what I've always wanted to turn this into is something that I collaborate with friends and family and friends who I consider family. And that's what makes this episode so incredibly fun for me. I've been lucky enough to surround myself by friends who are going to be excellent physicians and I know who are just crushing it at their jobs. And they make conversations like this much more entertaining to listen to and be a part of. Since I've started doing a lot of the social media stuff of medical education, I've seen some posts recently where people have been talking about how difficult med school is and how that's one of the hardest times of their lives. And personally, for me, when I look back at medical school, I view it as one of the best chapters of my life. And it's because I found a group of friends who made that time of my life so incredibly easy and just like smooth. Like, obviously, there's parts of medical school where there's trauma and there's hard times and there's failures. But being around this group of people made me realize there was more to life than the scores that you got and the exams you took. And this person who we're going to be talking to today was somebody who really changed the trajectory of where my med school life was going. When I first met Jeremy, I felt like I found somebody who was just like me. And it was refreshing because I didn't know that I was going to find somebody with a similar personality or had similar interests outside of medicine. And I think finding people like that is what made me develop such a strong group of support system and peers who, at the end of the day, all want to succeed, but also knew how to have a good time and how to just sink into the drama and trauma that comes with medical school. So for anyone out there who's listening, who's grinding away medical school, just try and find those people who really make you feel like a human and who make you feel whole and will pick you up when you're down. So with all that, I want to welcome in Dr. Jeremy Silver, who is an orthopedic resident at Rutgers University. He is in his PGY4 year and I believe has plans to go into sports medicine or ortho, sports ortho for his fellowship. So he will be finishing up orthopedics next year. And I think he's in the midst of application season for his fellowship. But today's episode, we're going to be talking about trauma, different types of trauma, what the primary and secondary survey look like, and then dive a little bit deeper into what orthopedic injuries can land somebody in the ICU. So, with all that being said, what's up, Jeremy? How are you?
Hey man, it's an honor to be on this podcast. I'm an avid consumer of your product. It's been awesome to see all the things you've been able to put together. So truly, it's an honor to be here. I'm excited about it.
It was a no-brainer picking you as like one of my first friend guests. One, because like I mentioned, we're just very similar people and we get along so well. But two, it is like one of the most ultimate compliments when I hear my friends saying that they listen to the podcast. And you have given me very good criticism in terms of how I can make this podcast better. So I truly do appreciate you listening with an active ear and supporting the show and the product for what it is.
Absolutely. I'd be lying to you if I wasn't saying or thinking to myself that I was hoping I'd find myself in this position. So happy to be here.
Here we are. Here we are. So before we get into the medicine stuff, you got to tell me how last night was.
Man, last night was incredible. So we went to a Jai Wolf concert. One of my longtime friends from middle school, Sajib Saha, is kind of like a producer DJ that you and I went to a concert back when I first met my wife. Really, I think it was my third date with my wife,
Wow.
Mary, who's
Wow.
an OBGYN resident at Temple.
I
We
forgot how
played one of,
early I forgot how early that
yeah,
was in your relationship. Wow.
yeah, dude. Yeah, it was early on. We took a big group trip to Philly from Hershey, kind of one of our early group, like friend group trips from med school to Philly. And we'd only been on a couple dates, so I invited her, and I was like, you know what, let's give it a shot. So it was a cool experience to go back. I find myself a little older and with a little earlier responsibilities nowadays. So I'm not gonna lie, it was a little tough to be out past midnight, but well worth it.
Oh, I bet. And just to fill in more of the context, Mary surprised you with these tickets, right? For your birthday, I'm assuming.
Yeah, so she got we saw Jai Wolf was coming to Philly, and it just kind of worked out with the schedule, and it was nice. I texted him. We were able to kind of chat with him after the show, so it was cool to do it. And I think we decided it was like 6.5 years after our first concert, so it was cool.
Dude, that's so awesome. I remember that first concert where you're like, yo, I'm gonna go hang out backstage in the green room with Jai. And I was like, if I was dating Jeremy, this is like major points. Like talk
Yeah,
about major points when you're first starting to date somebody.
yeah, it definitely looked pretty cool. And it just kind of worked out that way. We went backstage and got to hang out with him and enjoy that show. So it definitely made me look good.
I was watching Mary's Instagram story earlier this morning, and Indian Summer was playing, and that song still like gives me chills. It's like that's what a career defining song for that guy.
Dude, totally. And it kind of set him off. That really kind of popularized his music. And he's since come out with a ton of good stuff, but that's definitely like his main hit. And I urge anyone that's listening to this podcast to put on Indian Summer by Jai Wolf.
Yeah, you won't regret it at all. So
Yeah.
how did a small town kid from Pittsburgh end up going into orthopedics?
It's a good question. I kind of wasn't sure what I wanted to do when I went to Penn State. I was, my brother went to Penn State, and I was kind of looking at colleges, and I decided to go there with really no idea. At some point early in my college career, I was just kind of walking around, and I heard someone mention biomedical engineering, and I was kind of looking for majors. I was major shopping, if you will, and that sounded cool. I was kind of into it. To make a long story short, I went through biomedical engineering. I tried it for a little bit. I ended up getting my master's and working for a device company, but decided that route wasn't really for me, and had always thought about medical school. So I decided about a year after kind of joining the workforce that I would try to go back to med school. So it didn't. It kind of helps that I broke a bunch of bones as a kid. So to end up now here and as an orthopedic surgery resident, another kind of full circle moment.
Builds a lot of compassion, I bet, for your patients because you can kind of put yourself in their shoes.
Yeah, man, it was a bummer. I had to go through a lot of orthopedic surgeons, a lot of like pediatric stuff, and to miss a season or to break a bone and be in pain and have to go through that rehab process certainly um, kind of brings another perspective to it. It's something that is easy to lose when you're going through a grind of a long day and seeing a million patients with broken bones and different kinds of things. So I think it's important to have that perspective, and certainly having injury history yourself is a very common theme. So
Totally. And when you're first starting off residency, obviously there's a big jump from being a fourth year medical school, where honestly the second half of fourth year at Penn State was pretty chill and you get to travel the world. So unless there's a world pandemic going on, then you guess you're stuck inside. Um,
yeah.
but when you take that jump into intern year and you are told, hey, you're going to handle all the trauma that's coming in from into Rutgers, what is that feeling like when you realize, oh my God, I am the doctor who has to handle this catastrophe?
Yeah, it's insane. Insane in a bunch of different ways. Some good, some bad, but some necessary. You talked a little bit about our med school experience. It was completely different than anything that I've been through in residency. Med school is hard, but in a very different way. It's a ton of information. You're learning a lot about different organ systems. You're taking a ton of tests. You're learning the fundamentals of medicine, both physiologically and then towards the end, starting to clinically. When you become a resident, I really don't think there's a whole lot that can prepare you for like holding a trauma pager and being on the front lines. I think it was my first month I started on trauma, and day one you have the pager, and so pagers will go off and you're kind of first on the scene running things in the trauma bay. You have a little bit of training, you go through ATLS training and things like that to get you ready, but nothing compares to getting a page and walking swiftly or running sometimes towards the trauma bay to get ready. So it's an exciting time. It's a nerve-wracking time for sure. But luckily at a place like Rutgers is a level 1 trauma center, you get your reps in early and often, and you quickly become comfortable kind of going through everything.
And take us through that process. So you're holding a trauma pager. What are the different levels of trauma pages that you get through your pager, and which ones do you go to?
Yeah, so every place is a little different. I think when I started, it was a little different than it is currently. Right now, we have traumas Alpha, Bravo, and Charlie. Alpha is your kind of most severe trauma. I think they used to be called trauma codes when I was an intern. But these are kind of the sickest patients, the ones you're most worried about. Bravos are kind of a little one rung under that. There's different criteria that the EMS or whoever nurse is kind of calling the shots in terms of making it an Alpha, Bravo, or Charlie. So the Bravo is the middle. The trauma team at our hospital goes to all Alphas and Bravos. The Charlies are kind of the lowest rung of the trauma ladder, if you will. The emergency department attendings are the ones running those traumas. But they can be upgraded at any point to a Bravo or an Alpha if they come to the bay and the emergency department team doesn't feel like it's an appropriate Charlie. They can upgrade it, at which point we'll get a page as the trauma team to go to the trauma bay and kind of take over that evaluation.
And when you're the one in the trauma bay, take us inside the trauma bay. Like what team members are all around the patient?
Yeah, so as with most things in medicine, especially these days, it's a completely interdisciplinary team. So in a trauma bay, you have trauma interns or trauma residents at Rutgers. The trauma intern holding the pager is responsible for kind of running the trauma. So you're all gowned up. You have, a gown on, you have eye protection on, you have a stethoscope, you have everything you might need to run a code. There's an ultrasound. We're right next to the CT scanner. Portable X-ray shows up in case we need to do a chest X-ray or pelvic X-ray. There's emergency room nurses that are documenting everything. There's techs there to help roll people and take off clothes or interpret. The trauma senior, generally a resident in their later part of their general surgery training, is also in the room, kind of overseeing everything, gowned up, and ready to kind of intervene if the trauma intern or whoever's kind of primarily running the code misses a step or is unsure of what to do. And then above them, you generally have a trauma attending physician who's a surgeon who's there really overseeing everything. So if they don't see something they like, or if they see something concerning, they'll jump in right away and kind of steer the ship. So there's residents, there's attendings, there's techs, there's nurses, there's radiology techs. Occasionally, anesthesia will come down. I don't know how it is at your hospital, but that's kind of the who's who in the trauma bay.
Hey, do you have a good story of when a trauma attending was in the room and didn't like what they were seeing?
Yeah, there was a trauma attending when I was an intern who would just stop everything cold if he didn't like what he was seeing. So he would kind of stand outside in the corner. You knew he was there, but wasn't really, in the line of sight. But the minute somebody skipped something or someone kind of breezed over something that he felt was really important, he'd scream, "Stop!" And then he'd turn in, he'd come in, and like everyone was like, all right, something happened, something we missed. And that was just his style. But it's always, I would prefer someone that was really there paying attention to someone that wasn't. So that was his style. But there's a ton of stories about, you can be a little more relaxed. You kind of know when there's a trauma patient that doesn't necessarily need everybody's full attention, but when there's something that's really time sensitive, chest tubes will go in fast, or central lines will go in fast, that kind of level of awareness can heighten. So you never know what you're going to get in a trauma bay.
How much has your confidence grown in these 3, almost like going on your 4th year?
Yeah, it's interesting. So when you first start out, you're an intern, especially as an orthopedic intern, you spend a fair amount of time on the trauma service. When I was an intern, we spent 2 whole months on the trauma service. So holding a pager overnight on the weekends, running traumas. Pretty quickly with the volume we have, you get very comfortable running a trauma. So by the end of your first month, certainly you feel comfortable with the kind of sequence of events, running a trauma and doing all these things. And then as you move later on into an orthopedic career, your focus is different. We don't have an orthopedic resident or representative at all traumas, but we're always in the hospital. And when you're a junior resident, we spend a ton of time in the emergency department responding to traumas that have open fractures or obvious deformities and things. And pretty quickly you become confident in that you're kind of that expert. The general surgery trauma team knows a ton about the abdomen and overall management, but you as the orthopedic resident, even as a PGY2 or a PGY3, are really the expert on extremities and fractures and things. So by the time we're through our kind of junior residency, quote unquote, when I'm now in my 4th year, you are extremely comfortable managing almost anything orthopedically that comes in. And that's in addition to kind of your experience as an intern on the general surgery side of things.
Cool. And we're going to dive into some of those orthopedic trauma injuries. But take us through what the primary and secondary survey look like for a trauma patient.
Yeah. So, everything's very formulaic in general. There's a framework to responding and managing trauma patients, and it's all kind of based on this ATLS protocol that I mentioned. So a primary survey starts with, the A, B, C's, D's, and E's. So airway, breathing, circulation, disability, and exposure. So the way those are set up is it's basically the most life-threatening thing first. You want to make sure that they have an airway. Are they talking to you? Do you hear gurgling? Are they, do you feel like at any point the airway is compromised? And if so, you need to address that first. And these things kind of work in a cyclical nature. So even if you've moved through A, B, C, and you're on D, if something happens and you're worried about the airway, you go right
Mm-hmm.
back to A. So
Mm-hmm.
that's kind of how the process works. So you go through A is airway, breathing. You're looking for breath sounds. Are they satting okay? Circulation, you're feeling for pulses. You're looking for a blood pressure, vitals, things like that. Once you're through there, disability is really kind of getting an idea of their mental status. There's something called a Glasgow coma score that you calculate, and it's a scale from 3 to 15, and it gives you a good idea of kind of a brief neurological status of the patient, and you can calculate that based on kind of some physical exam findings and some kind of mentation questions as well. And then E is exposure, close off. You're looking for any obvious deformities, burns, things like that, that would compromise any sort of anything that may be missed if you didn't, take off someone's pants because they were driving their car and ended up on a backboard and in the trauma bay. So once you kind of go through your primary survey, you're making sure that the patient's stable enough that you can proceed. Like I said, at any point, if there's any question about one of the kind of A, B, C's, D's, and E's, then you go back to that before you move on to your secondary survey. If the patient's stable enough, then at that point, the secondary survey is basically a head-to-toe exam of a patient. You're getting a history, you're getting a little more medical history that might be relevant. And you're going from head to toe, looking at the entire patient to make sure you're not missing anything. And then kind of coupled with that, you have your adjunct imaging type things, a lot of ultrasounds. A lot of trauma patients get what's called a fast exam to look for fluid in the abdomen. You can get a cardiac ultrasound. You can get a chest x-ray. You can get a pelvic x-ray. All of those things are kind of tools at your disposal to use. And so that's kind of the main setup in the trauma bay. Patient comes in, you get report from the EMS. They're transferred safely to protect the spine and any sort of injuries that you might not be aware of over to the trauma bay. And then from the outside, it looks like all hell breaks loose, right? People are taking off clothes and screaming things, and whoever's running the trauma is being vocal about what they're seeing, so everyone's on the same page and it can be documented. But if you've been to enough of them, and if you have a good team, that organized chaos from the outside is actually very regimented
controlled chaos
and controlled. Yeah, exactly. Yeah. So those are kind of the main kind of way that we start doing a primary and a secondary survey on a trauma patient.
Awesome. Yeah, I think that makes sense. I think what you're describing, you just got to be there sometimes to like really fully appreciate the chaos of it. But it's helpful. I think it's helpful to sort of paint that visual for people. But what are some of the injuries that you get most concerned about as an orthopedic surgeon?
Yeah, when you're coming at a trauma patient from an orthopedic perspective, you're always looking at for open fractures. Is it open? Do they need antibiotics? Everyone makes a joke about orthopedics and ANSEF, but it really has the data.
That's the A and ABCs.
That's the A and ABCs. ANSEF circulation is ANSEF to the bones. So it's true though. In when I'm not on the trauma side of things and I'm on an orthopedic side of things, if there's an open fracture, it's important to give tetanus and appropriate antibiotics. Time to antibiotics has been shown to be the biggest preventer, I should say, of infection too. So you're looking for open fractures. You're looking for anything that is immediately life-threatening. So we're talking about pelvic fractures. Unstable pelvic fractures are the pelvis can hold a lot of blood, so that's something we're always worried about. Long bone fractures, femur fractures, especially bilateral femur fractures. We're looking for any kind of crepitus, bony pain, tenderness. We're pressing on your clavicles, your shoulders, your elbows. We're pressing on the pelvis to see if it's stable. We're looking at your femurs and tibias. We're asking you to move your fingers and checking to make sure that your neurovascular status to the extremities is intact. So the way I think of it is like doing an orthopedic specific secondary exam. So if I'm responding to a trauma, the trauma team calls me and I'm the junior orthopedic resident on call. I'm coming to the trauma bay, and of course they're worried about the ankle that's 90 degrees sideways, which I will take care of, but I'm also looking at everything else. I'm making
Right.
sure that we're
Right.
not missing anything either. And then, the main principles I always say, like, our job's not that hard. If something is crooked, you try to make it straight and splint it in that position. If you suspect that there's a unstable pelvic fracture, then you need to put a binder on, which is either a sheet, or they make these pelvic binders that can kind of close down the pelvis and minimize blood loss into the pelvis. That's kind of a main thing to do when you're in the trauma bay. And then, splinting things, and there's things like traction and all sorts of orthopedic tools that can help stabilize extremity fractures or pelvic fractures and stabilize a patient that can really be an issue.
Great. And then what types of injuries after you've stabilized them are you taking directly to the operating room as opposed to having the ability to sort of hold off until the next day?
Yeah. So it depends. Like I kind of mentioned before, this is all very interdisciplinary. So while an open fracture or an obvious deformity or a open book pelvic fracture that needs a binder is important, there are more life-threatening things than fractures and orthopedic problems. So once the trauma team has deemed a patient stable enough, or they've taken care of the kind of immediate pressing issues, then we can talk about timing in terms of taking someone to the OR. Things that generally need to go to the OR urgently from a kind of extremity perspective: mangled extremities, heavy machinery equipment, big traumatic amputations,
Hmm.
dirty wounds, things like that. Polytrauma patients that come in and have a bunch of open fractures may need to be taken to the operating room, but high energy trauma patients can come in with chest injuries and head injuries and things like that need to be taken care of first. So you try to stabilize them if they're in a stable position. Generally, if someone has like an open fracture, it can wait until 12 to 24 hours if it's an isolated thing. And we can talk a little bit about damage control orthopedics and different kind of ways to approach an orthopedic polytrauma patient. There's been a number of different kind of philosophies over the year. I know damage control orthopedics is one of them. There was something called early total care before that, where it was thought to, every orthopedic fracture needed to be managed right away to stabilize a patient. And that kind of turned into something called the second hit phenomenon, where a patient physiologically undergoes this big trauma, and then you take them immediately to the operating room and fix their femur fractures. And now you've put them through kind of a lot. So most of the time in orthopedics, things can wait some time after you've provisionally stabilized them.
Mm-hmm.
If it's a major polytrauma, they might go to the ICU to be resuscitated. They might be evaluated by neurosurgery, the SICU team, the trauma team for abdominal injuries and things like that.
Mm-hmm. Are there any specific patients that will end up in the ICU because of orthopedic injuries? I mean, obviously, if they need resuscitation, like you're already sort of hinted at, and they need pressors or they remain intubated, obviously those patients require ICU level of care. But are there specific orthopedic injuries that also just necessitate, sort of lead you into this answer, but like Q1 hour neuro checks or frequent neurovascular checks? Like, what are those types of injuries that really land somebody in a more acute care type setting?
Yeah. So, I mean, we could talk about like unstable spine fractures as a big one. Polytraumas with multiple long bone fractures. If someone comes in and they have an unstable operative pelvic fracture, they have, a femur fracture, an open tibia, an ankle, that's a patient that you're worried about. Whether they, if they don't have a head bleed or they don't have an abdominal injury, doesn't matter. A patient like that is someone that needs to be watched closely, because they can decompensate very quickly if you're not taking them to the operating room overnight. as an orthopedic resident, we cover a lot of spine trauma. And I think that's something. I'm actually on my spine rotation right now, and we're on spine call this week. So, every day there's a lot of spine trauma that comes in, and all trauma patients have spine fractures until proven otherwise. So we're very careful about keeping their neck immobilized. We're log rolling them safely, meaning just turning them with appropriate precautions. So if someone comes in and they go through the CT scanner and they have an unstable cervical spine fracture, or even before we get imaging, if they have some neurologic deficits and they have some back pain or neck pain, those are patients that we need to take care of quickly. We need to get the appropriate imaging, and they need to be in the ICU for, like you said, Q1 hour neuro checks to make sure that they're not decompensating if we're not taking them to the operating room right away. So spine trauma is really important. And I think, time is of the essence when you get imaging, and then also making sure that they're being transitioned appropriately to the ICU if they need it.
Sweet. Awesome, man. I think that was very valuable information. You definitely helped me really paint the picture of what the trauma rooms look like and what your role is. And even though you think your job is simple, I think you've done a phenomenal job at articulating what you do in a very simple manner. But I know what you do is not simple. I know there's a lot of decision making and a lot of data collection that goes into the way you make these decisions. And it takes a lot of reps, like you mentioned, and a lot of studying and a lot of reading. So even as simple as your job is, I know there's critical decisions that you're making on a regular basis. I hope spine is fun for you, man. I hope you enjoy it. I know it's one of the more exciting rotations. I think I think it's one of the things on Mike Barnum's future list of things that he wants to do.
Yeah. Yeah, we see a lot of spine trauma. One of the coolest parts about spine is, when you get comfortable enough evaluating spine patients, the physical exam can really match up with what's going on, anatomically. If someone has a cervical facet dislocation at C6 or something, you can basically tell what's going on based on their neurologic exam, where they're feeling numbness, where they have weakness and things. And while I'm going into sports medicine, which is very different than spine surgery, we have a really good experience learning about how to manage spine patients in the trauma setting. And then it's always interesting when you're evaluating someone and their imaging and their injury lines up with what you see. And that's always rewarding and makes you feel like you kind of know what you're doing.
Totally. All right. In closing, since we're talking about trauma and you've seen obviously lots of trauma, this is your opportunity to give a PSA to everyone listening of some of the silliest and most avoidable traumas that people find themselves in. So what is one piece of advice you'd like to give someone so that they never find themselves in your trauma bay?
Well, I have many pieces of advice. I could be here for a while. Some people are just unlucky, right? There's plenty of stories where you're in the wrong place at the wrong time, stray bullet hits you in the carotid or something like really intense. That is the vast minority of people that come into the trauma bay.
Talk about the most extreme reason to end up in the trauma bay.
Exactly. So yeah, so that was my first week on trauma.
Wow.
That was a wild one. Yeah, super sad and really kind of eye-opening. However, that is definitely the exception to the rule. So the worst injuries I see are motorcycles, high energy, fast motorcycles, not wearing a helmet, people falling from heights. We see a lot of high energy, like workplace injuries, doing something stupid on a rooftop. Those kinds of things are where you can get in trouble, and you can get in trouble quickly. So if you feel like riding a motorcycle, wear a helmet, don't speed, things like that. That's the biggest piece of advice anyone can ever give you. Because if you ride a motorcycle long enough, you'll find yourself in the emergency department. From an orthopedic perspective, I'll take the the time to urge people to not use trampolines. Don't go to a trampoline park, please.
Wise.
Don't fall off the monkey bars. You'll have a very tired orthopedic resident who has to reset your both bone
Stabilize you.
forearm fracture for the sixth time that night. So
Oh man.
those are kind of the big ones. Wear a seatbelt. We see a ton of motor vehicle collisions, people ejected, thrown from the car. You never think it's going to happen to you, but we're right next to a bunch of interstates and we see it every single day. Wear a seatbelt. It'll save your life. So basic things really do matter. They don't happen often to most people, but when you do it for a living, you see it every day. So um, that's my PSA.
Yeah, perfect. Perfect. Well, dude, this was a ton of fun. I'm so happy we finally found the time to sit down and chat. And I hope this is the start of many more chats for us to come.
Agree, man. Thanks for having me on. Would love to talk about anything else you're interested in.
Absolutely. Well, I'm going to be seeing you tomorrow. So that's also awesome.
Dude, I can't wait. I'm ready for this 3-day weekend. Sign me up
It's
for that.
it's going to be super fun. This is why Indian weddings are so great because it's just nights, multiple nights of partying. And what better crew to party with than our med school crew?
Yeah, man. We do it right. Hopefully we'll all wear our seatbelts on the way to the wedding and not end up in, in the hospital.
That's right.
We'll keep it safe.
All right, man. Good chatting with you,
All right,
and I'll
buddy.
talk to you later.
You too, man.
Bye.
Bye.
If you like this episode of CMO, be sure to hit the subscribe button to the Behind the Drapes podcast, where you can hear more episodes just like this and have the new episodes downloaded to your homepage as they come out. If you want to check out some of the educational content that I put out, check out my social media page on Instagram and TikTok and YouTube, and that's at Keywords by Kenny, at Keywords X Kenny, and that'll get you to these short videos that I put out about different educational topics related to anesthesia and the ICU.